Welcome back, guys. We have already discussed that how exactly the thyroid hormones are produced. We have seen how T3 is produced and T4 is produced, and also we have discussed about the differences between the T3 and T4. I have explained to you that the T3, the thyroid hormone, the T3 triiodothyronine is the active form and T4 is the inactive form. Yes, we have discussed about that. Now, let's see what exactly these thyroid hormones are doing to our body. These are catabolic hormones, right? So what exactly they are doing to our body, now we will discuss. See the summary of thyroid hormones, summary of the effects of the thyroid hormones. Now, what these thyroid hormones are doing to our heart? Simple thing. Try to understand the thyroid hormones are more like sympathetic hormones. Okay, so sympathetic hormone increases our heart rate. In the same way, thyroid hormones also increase our heart rate. That is a positive chronotropy. Okay, positive chronotropy increases the heart rate. So, how exactly thyroid hormones are increasing our heart rate is, see, now let's imagine this is our myocardial cell. Now let's take this as our myocardial cell. Okay, that's a heart cell. Now on this myocardial cell, yes, there are these beta 1 adrenergic receptors present. Okay, initially there are 2 beta 1 adrenergic receptors. Okay, in this part of the myocardium there are just only 2 beta 1 adrenergic receptors are present. Now, under the influence of thyroid hormones, now see the thyroid hormones are going to act on this myocardial cell. Now, under the influence of the thyroid hormones, now what happens is, now more number of beta 1 adrenergic receptors. Okay, sorry, it's not the beta 2, beta 1. So, beta 2 are present on the lungs, we all know that. So, at the end of the day, what I am trying to put into your mind is, see, under the influence of this thyroid hormones, once the thyroid hormones acts on this myocardium, now myocardium is going to synthesize and it is going to keep more beta 1 adrenergic receptors. More beta 1 adrenergic receptors means now this part of the myocardium, this myocardium becomes more sensitive to circulating catecholamines. Even a little amount of catecholamines can powerfully stimulate the myocardium because more number of receptors are there. Now this myocardium becomes more receptive to catecholamines. Okay, so by that thyroid hormones are increasing the heart rate. See, thyroid hormones on the heart, what they are doing, increases the number of beta 1 adrenergic receptors. Beta 1 adrenergic receptors makes the myocardium sensitive to circulating catecholamines. Okay, now the catecholamines, what are the catecholamines? Norepinephrine, epinephrine as well as the dopamine. Now these catecholamines can easily stimulate the myocardium because more number of receptors are there. Now if it can easily stimulate the myocardium, yes, heart rate will automatically increase because catecholamines increase the heart rate. We all know that. Now on the adipose tissue. Simple, easy peasy. Thyroid hormones are catabolic hormones, so adipose tissue is going to be broken down. So lipolysis. Thyroid hormones are catabolic hormones. So what about the proteins? Proteins are also going to broken down. See, muscles, what happened? Muscles are going to get broken down. The proteins, muscles are made up of proteins, right? So protein breakdown, proteolysis, lipolysis. Now on bone. Now here important point. See, usually thyroid hormones are breaking hormones. They will cause breakdown. They break down. So, but one important exception, actually I should say 2 important exceptions. Say on the bone, especially during childhood, the thyroid hormones will increase the bone length. Our thyroid hormones helps in bone formation, bone growth. Okay, we all know the thyroid, we all know that the growth hormones actually help in bone growth, but not just the growth hormone, but also the thyroid hormones do play important role in bone growth. Okay, so bone, see, growth and development of the skeletal system. Yes, growth and development of the skeletal system. It's true. Now, in the CNS, again same, during childhood or even during the embryogenesis, the thyroid hormones do play a very important role in the formation, in the development of the central nervous system. Especially, it is believed that thyroid hormones play a very important role in the formation of the synapses between the neurons. Okay, that junctions. Okay, chemical junctions. So synapses are formed mainly because of this thyroid hormones. So CNS, yes, developmental role. Bone, yes, developmental role. Now that's why we say if a baby is having congenital hypothyroidism, okay, that baby is going to suffer with dwarfism. Why? Because thyroid hormones do play a very important role in bone formation, bone growth. If a baby is having congenital hypothyroidism, that baby is going to have a stunted growth. Dwarfism is going to be seen, and that baby is not going to have a normal intellect like you and me. Why? Because the thyroid hormones are very much important for the development of the central nervous system. Now in this baby, the central nervous system is not developed, so this baby will be having mental retardation. So this condition is called as a cretinism. Cretinism. What exactly is cretinism? Congenital hypothyroidism. Okay, congenital hypothyroidism leading to dwarfism as well as a mental retardation is called as a cretinism. So cretins are those babies who doesn't have enough amount of thyroid hormones. Okay. Now after that, let's discuss about the thyroid hormone actions of the gastrointestinal tract. Thyroid hormones increases the GI motility. Okay, just remember thyroid hormone increases the GI motility. Not only that, thyroid hormones also increases the glucose absorption. See, try to understand. Thyroid hormones also increase the blood glucose levels. Thyroid hormones, just like growth hormone, increase the blood glucose levels. Yeah, growth hormone also increase the blood glucose levels. Thyroid hormones also increase the blood glucose levels. So both are hyperglycemic hormones. Both are diabetogenic hormones. Okay, why? Because both of them increase the plasma levels of glucose. So thyroid hormones, they act on GI tract, means by acting on the GI tract, they increases the glucose absorption. Not only that, please remember thyroid hormones increases the GI motility. Increases the GI motility. If the thyroid hormones are not there means, okay, the thyroid hormones are not there means GI motility decreases. If GI motility decreases, that will cause constipation. That we will see in hypothyroidism. Okay, but for now, thyroid hormones increases the GI motility. That's it. Thyroid hormone increases the glucose absorption. Done. Now, on the cholesterol, what it will do? So, it's a catabolism, again catabolism. Thyroid hormones in physiological quantities, it's very good. Why? Because the bad cholesterol in our body, the LDL cholesterol, okay, which is there. Now, we need to take out that LDL. So, first of all, LDL need to be uptaken by the liver. For that, the LDL should have to come and bind with its receptors. So, what happens whenever the thyroid hormones are there? The thyroid hormone acts on the liver. Now, under the influence of thyroid hormone T3, the liver will produce more LDL receptors. Now, this LDL will be taken and this LDL will be cleared away. So, what is happening with the cholesterol under the influence of thyroid hormones? Say, increased clearance by formation of new LDL receptors. More the LDL receptors, more easily the LDL will be taken up by the liver and will be cleared away. Okay, good. Now, throughout the body. So, what these thyroid hormones are doing? Out of all this is my favorite thing. Okay, this is my favorite. Now, please try to understand. See here, this is one cell. Okay, you can take it as any cell. Okay, you can take it like any poset, anything. See, normally on this cell, there is this one important pump present. Okay, so if I am calling it pump, yes, you should understand that it uses energy. Pumps are the ones which uses energy. Okay, now there is this one important pump present which is taking 2 potassium into the cell. Okay, it takes 2 potassium ions into the cell and it throws 3 sodium ions out of the cell. 3 sodium out, 3 sodium out and 2 potassium into the cell. The same thing, this is also doing the same thing. Now, what exactly is this? Sodium, potassium, ATPase. Okay, our favorite thing which is present on almost all the cells is sodium, potassium, ATPase. Yeah, it is maintaining the chemical balance, like the electrolyte balance. The sodium more outside the cell, potassium more inside the cell. It is doing its job. Okay, well and good. But under the influence of thyroid hormones, okay, once this T3 comes, now what this T3 is going to do onto the cell? Okay, what this T3 is going to bring changes onto the cell is, under the influence of this thyroid hormone. First of all, remember, now itself I am telling you that thyroid hormones do not have the receptor on the cell membrane. Okay, thyroid hormones do not have the receptor on the cell membrane. Even the thyroid hormones doesn't have the receptor in the cytoplasm also. Thyroid hormones have the receptor in the nucleus. Thyroid hormone receptor is present in the nucleus. It's the intranuclear receptors. Okay, so intranuclear receptors are present for thyroid hormone. I used to remember like the mnemonic sex with T3 T4. Okay, sex with T3 T4. Sex hormones with let me write it down here. Sex with T3 and T4. So, what is the sex with T3 T4? See, the sex hormones, vitamin A, okay, sex hormones, vitamin A and T3 T4, these hormones are having the receptors within the nucleus, intranuclear receptors. See, within the nucleus means it's such a lonely place, like the sexual activity which happens in a very a lonely place. Even the receptors, okay, these hormones like sex hormone receptors, vitamin A receptors and T3 T4. So mnemonic sex with T3 T4 is happening. All these receptors are present within the nucleus. I used to remember it like that. If it helpful for you, you can take it. So at the end of the day, yeah, thyroid hormones are acting on the cell. Now, when thyroid hormone acts on the cell, at the end of that, what happens is the number of the sodium potassium ATPases, okay, the number of sodium potassium ATPases are increasing more in number. Now, more number of sodium potassium ATPases are there. Now, tell me, so thyroid hormone, what it will do? The thyroid hormone increases the number of sodium potassium ATPases. Done. Now, this is half of the story. Now, we all know that what are the functions of thyroid hormone? Thyroid hormones, okay, thyroid hormones are calorigenic hormones. So, we all know that the thyroid hormones are calorigenic hormones, and also thyroid hormone increases the basal metabolic rate. Okay, so my question to you, so what exactly is this basal metabolic rate? Okay, what exactly is basal metabolic rate, BMR? See, basal metabolic rate means the number of calories needed for 24 hours for all the biochemical reactions in the body. Okay, in a simple way we can say something like this: to keep this body alive for the next 24 hours, to run this body, okay, for example, an adult body of 70 kilos or 75 kilos, to run this 75 kilo body for the next 24 hours, how many calories are needed? Okay, how many calories are needed, or how much energy is needed? Okay, in a more complicated way we can say, like, for all the biochemical reactions, for the maintenance of the homeostasis in the body, how much calories are needed? That is nothing but basal metabolic rate, okay, in a simple way. So thyroid hormones increase the basal metabolic rate. We all know this. Okay, thyroid hormone increases the basal metabolic rate. For example, now if I say my basal metabolic rate is 2700 calories. So for running this body for the next 24 hours, I need 2700 calories. But if I start to take more thyroid hormones, okay, if I start to take more thyroid hormones, or by any chance, if thyroid hormones increase my body, now I require more calories. I will burn out more calories to run the body. Okay, so thyroid hormones increase the basal metabolic rate. Now how that actually happens? See, I have already explained to you. Thyroid hormones, what they are doing? By acting on the cell, they are increasing the number of sodium, potassium, ATPases. Previously, there are less number of sodium, potassium, ATPases. So less ATP is getting broken down. Less ATP is going to get broken down, means less calories are utilized. Okay, less calories are utilized. Now, under the influence of thyroid hormones, what happens? More number of sodium, potassium, ATPases. More number of sodium, potassium, ATPases means more ATP are getting broken down. More ATP are getting broken down means more energy is getting released. More energy means whenever the ATP is getting broken down, energy is released in the form of temperature. So that's why we say thyroid hormones are calorigenic hormones. Okay, they increase the body temperature because ATP is getting broken down, energy is released in the form of heat. So that maintains our body temperature. Okay, well and good. Not only that, the thyroid hormones, what they are doing? Increasing the sodium, potassium, ATPases. More ATP is getting broken down. More ATP means more calories are utilized. Okay, more calories are utilized now. More calories are getting utilized. So what happened to the basal metabolic rate? Instead of using 2700 calories, I will be using 3500 calories or 4000 calories. Okay, in a day I am spending more calories, more number of energy is getting used away. Okay, I am just using more amount of energy. Okay, so that's why thyroid hormones are said, like, they increase the basal metabolic rate in a simple way. So now throughout the body, what is happening? See, it stimulates the oxygen consumption. Yes, more oxygen will be utilized by the cells. Okay, why? Because ATP is getting broken down, right? So stimulate the oxygen consumption, increases the basal metabolic rate, BMR. How? By increasing the number of sodium, potassium, ATPases. See, the thyroid hormones are going to increase the sodium, potassium, going to increase the basal metabolic rate by increasing the sodium, potassium, ATPases in all the places of the body, except exceptions. Okay, BMR is not increased in testis, uterus, okay, in testis, uterus, lymph nodes, spleen and anterior pituitary. These are the exceptions. Okay, these are the 5 sites where the basal metabolic rate is not going to be increased. Okay, so these are in general about the thyroid hormones, effects of the thyroid hormones on different tissues of the body. Important points which I want you to know is thyroid hormones are calorigenic hormones. Thyroid hormone increases the basal metabolic rate by increasing the number of sodium, potassium, ATPases. Thyroid hormones are catabolic hormones. They will cause breakdown of proteins. True. They will cause breakdown of lipids. True. Thyroid hormones increases the glucose levels in the blood. So that's why hyperglycemic hormones. But important point is thyroid hormones are developing the bones. Thyroid hormones are developing the central nervous system. So deficiency of thyroid hormones during childhood will cause mental retardation, as well as deficiency can also lead to the stunted growth. Okay, dwarfism as well as the mental retardation. Those babies are called as the cretinism. Okay, cretinism. And on the heart, thyroid hormones are going to increase the heart rate, positive chronotropic effect by increasing the number of beta 1 adrenergic receptors. Done. Now, in this slide, let's discuss the differences between hypothyroidism as well as the hyperthyroidism. Okay, hypo as well as the hyper. Hypothyroidism means what? Hypothyroidism means T3, simple. T3 is going down, T4 is going down, T3 going down, T4 going down. And hyperthyroidism, T4 levels are more, T3 levels are more T3, more T4. Now, first let's start with the hypothyroidism. Hypothyroid. Now, try to understand. Normally, thyroid hormones increase the basal metabolic rate. If thyroid hormones are there, means yes, you are utilizing the energy. You are spending out the energy. You are taking out the you are easily spending the energy. Okay, catabolic hormones. Whenever the hypothyroidism means no, you are not spending the energy. Okay, the lipids are not going to get broken down. No proteins are getting broken down. No lipids are getting broken down. You are not using the energy. Basal metabolic rate becomes low. Instead of using 3000 kilocalories, now you are just using 2000 kilocalories or 1700 kilocalories. So you are not using the energy, you are not spending the energy. If you are not spending the energy, you will become obese. Okay, so that will cause hypothyroidism, will cause obesity. Okay, as the basal metabolic rate is not much, you don't need much calories, you don't need much food. So what happened to the food intake? They will take less food. So less food intake will be seen. Okay, and what about the body temperature? Usually these fellows are going to be having less body temperature. Why? Because thyroid hormones are the calorigenic hormones. Whenever there is hypothyroidism, the calorie production or the calorigenicity, the temperature production is going to decrease. And when the temperature is going down, that will cause cold intolerance. If you ask this person to sit in an AC room, okay, you just take this person and ask him to sit in an AC room, he cannot stay there. Why? Because already his body temperature is less. So he will like to sit in a hot environment. So if you ask him to sit in a cold environment, he cannot sit there. So that is cold intolerance. So hypothyroidism patients will be having cold intolerance. Now about the GI motility, I have explained to you, thyroid hormones increase the GI motility. Now these fellows, no GI motility is seen. If no GI motility means constipation. Okay, they will be having constipation, and especially in these females, we don't know the exact reason why, but hypothyroidism is associated with menorrhagia. Okay, the range can be menorrhagia to amenorrhea. Menorrhagia means excessive bleeding. Okay, menorrhagia means like excessive bleeding is there. Excessive bleeding means almost more than 70 ml of blood or 80 ml of blood is going to be lost in during the menstruation. Usually 30 to 50 ml is the normal range. Okay, 30 to 50 ml is the normal range. If she is losing more than 70 ml of blood, or if she is having menses for more than 7 days, then it is considered as menorrhagia, excessive bleeding. Okay, so initially it will start with menorrhagia, but at the end of the day, okay, after a few months, now she will end up in amenorrhea. So too much amount of blood loss can even lead to anemia. Too much amount of blood loss can even lead to the anemia. Okay. Okay. Now after this, what else can be seen in the hypothyroidism is tendon reflexes. The tendon reflexes are going to be decreased. Okay, why? Because thyroid hormones are more acting like a sympathetic hormones, right? Okay, they are helping in the central nervous system excitation, CNS development. So whenever the thyroid hormones are going down, even all the reflexes in the bodies, okay, even all the reflexes in the bodies are going to be hampered, okay, delayed. So tendon jerks, okay, tendon jerks are the knee jerks, ankle jerks, all these jerks will be delayed. See, this is the most important pathognomic sign. The most important reliable sign, or I should say the most specific sign in hypothyroidism is hung up ankle jerk. Okay, hung up ankle jerk or the delayed ankle jerk. Okay, hung up ankle jerk or the delayed ankle jerk is the most reliable sign in hypothyroidism. Okay, when you tap on the Achilles tendon, okay, on the foot, if you tap on the Achilles tendon on the back of your foot, usually you will be having a reflex like this, a jerk like this. Okay, so now in this hypothyroidism, because of the deposition of glycosaminoglycans over there, and because of all the stuff, now the reflex is going to be hampered. There will be a jerk like this, and it is going to come very slowly. So this is hung up ankle jerk. Now what else can be seen in hypothyroidism? See, the patient will be having loss of eyebrows. There can be macroglossia, mask-like faces. Usually these patients will be having depression. This is the one important point I want you to know. These patients are having depressions. Why? Because thyroid hormones, again I am saying, they are more like sympathetic hormones. They excite you. Okay, so excite the central nervous system. So whenever T3, T4 is not there, you will be having CNS depression. So the patients are they are more like moody fellows. Okay, they do not have any expressions. They are not going to talk with anyone. They are absolutely having depression. Okay, so these are some important points about the hypothyroidism. Now let's talk about the hyperthyroidism. Okay, more excitation. Okay, more sympathetic hormone like. Okay, more excitation. Okay, they will be having tachycardias. Okay, tachycardias. Here in hypothyroidism, please add one more point. Okay, hypothyroidism, the patient is having the bradycardias. Why? Because thyroid hormones increase the heart rate. Whenever the thyroid hormones are not there, usually bradycardia. Now hyperthyroidism, tachycardia. Okay, usually in you and me, for example, when we go to the sleep, our heart rate actually have to come down, but these fellows will be having resting tachycardia in hyperthyroidism. Okay, even during rest, even during sleeping, there is a tachycardia, and that's the most reliable sign of hyperthyroidism. What is the most reliable sign? The most reliable sign is resting tachycardia or sleeping tachycardia. Okay, apart from that, now their basal metabolic rate is increased, more number of calories are getting utilized, more number of calories are getting broken down. Okay, every day instead of using 3000 kilocalories, this patient is going to use 4000 kilocalories. So more energy is getting broken down. So the patient is going to become slim. So hyperthyroidism patients will become Now they will be having increased intake. Why? Because their demand is more, right? Okay, they need more calories. So automatically these patients will likely to take more food. So increase intake. Now what about the temperature? They are having more calorigenicity. Okay, more calories are getting generated, more BMR, more basal metabolic rate, more ATP are getting broken down, so more energy is getting released. So already their basal body temperature is more. So they love to be in cold environment. Okay, they don't like the hot environments. So it's a heat intolerance. So they don't like the hot environment. So it is heat intolerance. Now thyroid hormones increase the GI motility. Now here also more thyroid hormones, more GI motility. More GI motility means the proper absorption is not going to happen properly. So that will cause diarrhea. Okay, so these patients will be having diarrhea because of increased bowel movement, no proper absorption. That will cause diarrhea, and the females more likely to have the oligomenorrhea. Oligomenorrhea means irregular menses. Okay, usually the menses have to happen somewhere around once in every 28 weeks. That's something normal. But now these fellows, okay, the persons with hyperthyroidism, they will be having menses once in 2 months or 3 months, something like that. That's the oligomenorrhea. Okay. Now tendon reflexes. Now the tendon reflexes, thyroid hormones are more like sympathetic hormones. So more tendon reflexes. Tendon reflexes are increased, and they are like sympathetic hormones, right? So these patients will be having tremors. Okay, tremors will be seen. And if you look at the eye signs, okay, if you look at the eye signs, there will be 𝐒𝐳𝐽𝐵𝐷𝑒𝑚us. Okay, there will be 𝐒𝐳𝐽𝐵𝐷𝑒𝑚us. That's the protrusion of the eyeball, little anteriorly. 𝐒𝐳𝐽𝐵𝐷𝑒𝑚us, or proptosis can be seen, the protrusion of the eyeball anteriorly. Here you can clearly see. So this is how the proptosis will look like, the protrusion of the eyeball. And what else can be seen? There will be pretibial mixed edema. They use the word pretibial mixed edema. Okay, see, you have to answer the hyperthyroidism. Why I am saying so specifically is, mixed edema is something which is seen in both hypothyroidism as well as hyperthyroidism. Okay, in both hypothyroidism as well as hyperthyroidism, yes, mixed edema is seen. What exactly is mixed edema, I will discuss in a minute. But mixed edema is seen in both hypo as well as hyperthyroidism. But if they use the word pretibial mixed edema, look at here. See, this is the tibia, right? No, pretibial, on the tibia. Okay, there is this mixed edema. Okay, little bit edematous. It's not a pitting edema, but edematous condition. This is called as a pretibial mixed edema. We'll discuss about that. But anyway, see, pretibial mixed edema is due to deposition of mucopolysaccharides in front of the tibia. Okay, mucopolysaccharides in front of the tibia. That is pretibial mixed edema. And there will be acrobacy also. Acrobacy, why acrobacy? Thyroid hormones in excessive quantities, hyperthyroidism in excessive quantities will even cause the bone destruction that will cause subperiosteal bone resorption, especially in the fingers. Okay, subperiosteal bone resorption, especially in the fingers, is called as acrobacy. That can be seen. Okay, these are the late features. So in this slide, yes, we have discussed some of the important features of hypothyroidism as well as the features of the hyperthyroidism. Okay, now let's continue the differences. So what are the causes? Okay, now what causes this hypothyroidism? See, the most common cause of this hypothyroidism in India, is iodine deficiency. Iodine is not available, T3T4 is not produced, that causes the hypothyroidism. In worldwide also same thing, iodine deficiency. Okay, iodine is not readily available. Okay, so in India it's iodine deficiency, worldwide also iodine deficiency. But in Western world, the most common cause of the hypothyroidism is not the iodine deficiency, it's the destruction of the thyroid gland. Okay, the thyroid gland is getting destroyed. By whom? By the autoimmune destruction. The autoantibodies. Okay, the autoantibodies, now they are coming and they are attacking the thyroid gland and damaging the thyroid gland, destroying the thyroid gland. Okay, that's the autoimmune destruction, which is also called as the Graves disease. We will discuss. So sorry, not Graves disease, Hashimoto's thyroiditis. So Hashimoto's thyroiditis is the most common cause of hypothyroidism in the Western countries. But in India, it is the iodine deficiency. Okay. Now, this hypothyroidism, it will cause what? Okay, it will cause what? In children, it will cause cretinism. We have discussed. Okay, in pediatric age group, it will cause cretinism, where the babies are going to be having mental retardation as well as the stunted growth. Okay, cretinism is a condition. See, congenital hypothyroidism leads to cretinism. These babies are having decreased bone growth as well as the mental retardation. Okay, now in adults it is going to cause the mixed edema. So what exactly is this mixed edema? See, the thyroid hormones are very much important to take out the older proteins, even from our skin, even from our connective tissues. The older proteins need to be taken out. In the place of the older proteins, we need to replace with the newer proteins. Okay, the older proteins need to be constantly replaced. So the collagen, which is the most important fiber in our connective tissues, Now in hypothyroidism what happens is, now this collagen starts to accumulate. Okay, the collagen is not getting destroyed, the older proteins are not getting destroyed. Now this collagen will start to accumulate inside the connective tissue. Now this collagen will love to attract the water, it's a protein, right? Now it will love to attract the water. Now this collagen along with the water, it's forming edematous condition, that is called as a mixed edema, simple. It's not just edema, it's mixed edema because of the proteins. Okay, it's not a non-pitting edema, the proteins is there, we all know the proteins are having this osmotic power, it will drag the water with them, so causing edema. Okay, so this is mixed edema. Now important point is, there is a condition called as a mixed edema coma. Okay, mixed edema coma, that we will discuss later. Mixed edema coma is seen in, just a mixed edema coma is seen in hypothyroidism. It's a very severe complication, it's a severe complication of hypothyroidism. Okay, so in pediatric age group, this hypothyroidism is going to cause cretinism. In adults, it is going to cause mixed edema. I have already discussed with you the causes. In India and worldwide, the causes of the hypothyroidism is iodine deficiency. In Western world or the developed countries, it is the autoimmune destruction or Hashimoto's thyroiditis is the most common cause of the hypothyroidism. Done. Okay. Now, what are the causes? Okay. Now here itself I am discussing the causes of hyperthyroidism. Okay. What causes the hyperthyroidism? The most common cause is Graves' disease. Okay. The most common cause is the Graves' disease. So what exactly is Graves' disease? Simple. In Graves' disease, the patient is producing the antibodies. Now these antibodies, what they are doing? They are stimulatory antibodies, which are called as LATs. Okay, long acting thyroid stimulating antibodies. Okay, LATs, AB. Long acting thyroid stimulating antibodies. Now these antibodies are going to come and they are going to stimulate the thyroid stimulating hormone receptor. Okay, TSH receptor. Okay, now they are going to stimulate the TSH receptor. Now the thyroid stimulating hormone receptor is getting stimulated. So now thyroid gland is going to produce more amount of T3 and T4. So this is Graves' disease, which is primary toxicosis. So thyroid gland is getting stimulated by the antibodies. The antibodies are called as LATs, long acting thyroid stimulating antibodies. Done. Now what are the other causes of hyperthyroidism? Causes of hyperthyroidism. Second cause is the Plummer's disease. Okay, Plummer's disease. What is happening here? In the thyroid gland, some nodules are forming. Okay, adenoma, some small nodules are forming. These nodules are hot nodules. They are producing excessive amount of T3, T4. Okay, so independently they are producing excessive amount of T3, T4. So what is the difference? See, in Graves' disease, there is a diffuse enlargement of the thyroid gland. Okay, entire thyroid gland is diffusely enlarged. Okay, even there are cases where you will be having nodules, but anyway, usually in Graves' disease, that is the primary toxicosis. It's the thyroid stimulating hormone receptor antibodies. Okay, they are stimulating the thyroid gland, so that the entire thyroid gland become diffusely enlarged. Now this thyroid gland is producing T3, T4. Okay, what is Plummer's disease? Plummer's disease is an example of secondary toxicosis where there are nodules. There may be one nodule or multiple nodules. That if one nodule is there, then it is called as a solitary nodule goiter, SNT, solitary nodule goiter, or there will be multinodular goiter. Usually multinodular goiters are more common than the solitary nodular goiter. Okay. See, Graves is example of primary toxicosis. Plummer's is an example of secondary toxicosis. In primary toxicosis and secondary toxicosis, what is the difference? The primary toxicosis is diffuse, okay, diffuse enlargement, okay, with the simultaneous toxic features. Okay, at the same time there is diffuse enlargement as well as the simultaneous toxic features. Okay, all the toxic features, the hyperthyroid features. Okay, seen at the same time. Okay, now the Plummer's disease is an example of secondary toxicosis. A long-standing solitary nodule. Okay, first there will be a long-standing. Okay, a solitary nodule will be there. Okay, now later on the patient will develop the thyroid features. Okay, later on the patient will be developing the thyroid features. And one more important image-based question which I want to discuss here, is this Osborne wave. So what exactly is this Osborne wave? See, these Osborne waves are seen in conditions of hypothermia. Okay, they are seen in the conditions of hypothermia. See, just now remember, see these Osborne waves. Okay, see this small elevation is there right here. This is called as a J point. Usually this point is called as a J point. Whenever you have this elevation, okay, here this is called as the Osborne waves. Osborne waves are seen in hypothermia. Okay, they are seen in hypothermia. Now, why we are discussing about hypothermia here? Yes, we will discuss in a minute. See, guys, there is this one condition. Let me tell here itself. See, there is this one condition which is called as mixed edema coma. So what exactly is this mixed edema coma and how to treat it? See, mixed edema coma is a more severe complication. It's a more severe complication. Okay, usually try to understand. One female came to you and she is saying like, her menses are like, overbleeding is there during her menses. Okay, now she is feeling depressed. Now she is giving you all the complaints which is suggesting that she is having hypothyroidism. Okay, now you came to a conclusion, okay, this fellow is having hypothyroidism. You have run the laboratory test and it's very clear the T3 hormone levels, the T4 levels are very, very less. Now you came to a conclusion that, okay, this fellow is having hypothyroidism. Now, for the treatment of hypothyroidism, what drugs you are going to give? Simple, thyroxine, T4. Okay, levothyroxine is the drug which you are going to give for that female. Okay. See, now she is not in an emergency, so you can give T4. Okay, you can give T4, that's the levothyroxine. Later that T4 in her body will be converted into T3, the peripheral conversion will happen. Okay, T3 is going to do its duty. Now, this myxedema coma, which I am talking right now, it's an emergency condition. Why? Because, see, coma, myxedema coma. See, myxedema is seen in hypothyroidism. Yes, it is also seen in hyperthyroidism, but mostly seen in hypothyroidism. Myxedema, we know. The swelling, everywhere there is swelling because of the collagen. Collagen is like, it's absorbing the water and it's getting swelled and it's causing the extreme swelling. Okay, extremity swelling. That's the myxedema coma. See, why there is this coma? This coma is because, see, now these fellows are having a severe hypothyroidism, Whenever there is severe hypothyroidism, what happened to the BMR? BMR is very, very severely decreased. Okay, there is very drastic fall in the basal metabolic rate. So, the amount of calories which are utilized and the amount of heat which is produced is drastically falling down. Now, the body temperature is decreasing. Now, we all know that the enzymes will only function in normal body temperature. When the temperature is going down, automatically enzyme stops functioning. When the enzyme stops functioning, all the biochemical reactions, the thousands and thousands of biochemical reactions in our body are done by the enzymes. Enzymes are thermolabile, they are sensitive to the body temperature. Now, if your body temperature is going down, these enzymes stop functioning. When this enzyme stop functioning, especially even in the central nervous system, what happens? The patient will go into the coma. Okay, so that is myxedema coma. This is an emergency condition. So, what you have to do? You have to give the active T3, not the T4. You have to give the active T3, that is 𝐿𝐿𝐼𝐻. 𝐿𝐿𝐼𝐻 is the drug of choice. Remember, 𝐿𝐿𝐼𝐻. 𝐿𝐿𝐼𝐻 is active T3, which is used in the treatment of myxedema coma. Okay, so in a myxedema coma patient, if you do the ECG, you will have this wave, Osborn waves. So, what these Osborn waves are representing? Osborn waves are seen in those conditions where there is hypothermia. Okay, hypothermia. So, such hypothermia is seen in myxedema coma. Body temperature is going down. So, you will be having this Osborn waves at the J point. Okay, again I am saying you, myxedema is seen in both hypo as well as hyperthyroidism. If they specifically use the word pretibial myxedema, it is seen in hyperthyroidism. It is because of the reposition of the mucopolysaccharides in the tibia, in the shin region. If they use the word myxedema coma, it is a severe complication of hypothyroidism. The treatment is active T3, that is 𝐿𝐿𝐼𝐻. Okay. Now, yes, we are done with the differences between hypothyroidism as well as hyperthyroidism. But here, I want you to know one more important topic, that is the thyroiditis. Okay, thyroiditis. A few important MCQs are there. I am not going in detail. Because you will study the thyroiditis and the thyroid cancers anyway in the pathology. But a little integrations I want you to know. See, thyroiditis. If someone comes to you and asks you about the thyroiditis, will it cause hyperthyroidism or hypothyroidism? See, the causes of thyroiditis might be different. For example, there are viral thyroiditis, fibrosing thyroiditis, or bacterial thyroiditis, autoimmune thyroiditis. Different types of thyroiditis are there. Causes might be different. But at the end of the day, thyroiditis, will they cause hyperthyroidism or hypothyroidism? They will cause hypothyroidism. Okay, this is the important point. Thyroiditis results in hypothyroidism. Now, let us see how many different types of thyroiditis are there. See, there is Hashimoto's thyroiditis, Riedl's or fibrosing thyroiditis, de Quervain's thyroiditis, okay, de Quervain, okay, I should say de Quervain, yeah, de Quervain thyroiditis and acute bacterial thyroiditis. See, out of which the bacterial thyroiditis is not that important. Okay, I want you to know the Hashimoto's, Riedl's and de Quervain's, very, very important. Okay, now what is the cause of Hashimoto's thyroiditis? Hashimoto's thyroiditis being the most common thyroiditis. Out of all the thyroiditis, Hashimoto's thyroiditis is most common. You guys already know about the Hashimoto's thyroiditis. What exactly is happening in the Hashimoto's thyroiditis? Again, antibodies are coming and destroying. Now, not the stimulation, now the antibodies. Okay, these are not the LATs. These are not the long-acting thyroid stimulating antibodies. No, long-acting thyroid stimulating antibodies are seen in Graves' disease. Okay, Graves' disease. Now, these are the antibodies which are destroying the thyroid gland. They are going to destroy the thyroid gland. See, so Hashimoto's thyroiditis is the most common type of thyroiditis. Okay, where the antibodies, see, autoimmune thyroiditis, where the destruction of the thyroid gland is happening because of the autoimmune antibodies. So Hashimoto's thyroiditis, most common thyroiditis, also called as lymphocytic or autoimmune thyroiditis. Okay, sir, well and good. Now, here you are having antibodies. See, this ABS means antibodies. What type of antibodies? Yes, inhibitory antibodies, not the stimulatory antibodies, inhibitory antibodies. So, how many types of inhibitory antibodies are there? See, these antibodies are produced against thyroid stimulating hormone receptor. These antibodies are produced against thyroglobulin protein. Okay, our heroine, thyroglobulin. Okay, and the thyroid peroxidase enzyme. Okay, thyroid peroxidase is an enzyme which is helping in the oxidation, organification, coupling reaction. So, antibodies, inhibitory antibodies are produced against, yes, TSH receptors, thyroglobulin as well as thyroid peroxidase enzyme. Okay, now this Hashimoto's thyroiditis, how to identify, sir? Okay, see, in Hashimoto's thyroiditis, if you look at the biopsy report or fine needle aspiration cytology or biopsy, where you will see in FNS you will see this is the exact, like, histological view. See, you will see the Hürthle cells or Ashkenazi cells or oncocytes. Okay, they are all one and the same. Okay, they are big cells. Okay, big cells with abundant cytoplasm. Okay, and varying size and nuclei. Okay, they are called as the Hürthle cells or Ashkenazi cells. Okay, abundant cytoplasm with varying size nucleus. They are called as the Hürthle cells or Ashkenazi cells. Okay, so direct question for you. Hürthle cells or Ashkenazi cells are seen in Hashimoto's thyroiditis. Okay, autoimmune thyroiditis, chronic lymphocytic thyroiditis. See, here I want you to know two important points. Histological report of Graves' disease. Okay, Graves is an example of hyperthyroidism. Hashimoto's, see, Hashimoto's is a thyroiditis. Thyroiditis are all the time going to cause the hypothyroidism. Now, please look at here, guys. This is the histological report. Okay, see, this is the histological view of Graves' disease. See, this is the colloid. This pink color material is called as a colloid. Please appreciate in the periphery of this colloid. See, all this peripheral area, there is this white. Okay, please here also look here. So, in the colloid, the peripheral regions, there is a loss of colloid material. This is called as a scalloping of colloid. Okay, scalloping of colloid is seen. Now, whenever you listen this word, scalloping of the colloid, you should all the time think about, see, scalloping of the colloid is seen in Graves' disease. But in Hashimoto's thyroiditis, what you will see, Hürthle cells, Ashkenazi cells, oncocyte, all the same. Okay, they are all the same. So, Hürthle cells or Ashkenazi cells are seen in Hashimoto's thyroiditis. Okay. Now, what else are the important points which you need to know? For example, imagine that I am the person. Okay. Usually, Hashimoto's thyroiditis is most common thyroiditis, which is usually seen in the Western countries. Okay, Western countries. Hashimoto's thyroiditis is the most common cause of hypothyroidism in the Western countries. Now, imagine I am the patient. Right now, I am developing the Hashimoto's thyroiditis. What happens? I am producing the antibodies. Now, these antibodies, they will come and start to destroy the thyroid gland. Now, if my thyroid gland is being attacked, what happens? All the thyroid hormones which are already preformed, they are already stored in the colloid. Okay. Once if T3, T4 are produced, means they will be stored in the colloid for almost 3 months. Now, what happens now? My thyroid gland is being under attack. Okay, they are being under attack. Now, thyroid gland is getting damaged, colloid is getting damaged. So, now the T3, T4 hormones are going to spill out. They will spill out into the circulation. So, that will cause hyperthyroidism initially. Initially, there is a phase of hyperthyroidism. Why? Because the thyroid gland is getting damaged. So, there is spill of the already preformed thyroid hormone. So, at a time that will cause hyperthyroidism or toxic features. Toxic features are seen. But after that, what happens? All these thyroid hormones will be burnt out. Okay, used up. So, later there is a phase of hypothyroidism. At the end of the day, there is hypothyroidism. So, remember, so thyrotoxicosis. Initially, okay, actually this thyroiditis presents with the pain. Okay, Hashimoto's thyroiditis is painful. It's painful. So, initially there is a phase of thyrotoxicosis due to increased release, not the production. There is no production. Increased release is there. Later, what happens? A burnout. Okay, once the T3, T4 is used up, the burnout leading to hypothyroidism. Okay, so these are some important points which I want you to know. Now, after Hashimoto's thyroiditis, let's talk about the needles or fibrosing thyroiditis. So, fibrosis. Thyroid gland is getting fibrosis. Not only the thyroid gland, there is retroperitoneal fibrosis, laryngeal fibrosis. Even the fibrosis will lead to the Dupuytren's contracture. Okay, Dupuytren's contracture. You can see here. Okay, all this is like a fibrosing disorder where fibrosis is happening in different places of the body. Not only that, even fibrosis. We don't know the exact reason, but fibrosis is also happening in the thyroid gland. The entire thyroid gland is getting fibrotic. Now, If the entire thyroid gland is getting fibrotic, means what happened to the T3, T4 levels? T3, T4 hormone levels will automatically go down. The production of the T3, T4 will automatically go down. So that will cause hypothyroidism. So even Riedl's, yes, it is also causing hypothyroidism. It is associated with what? Associated with invasive fibrosing thyroiditis. Yeah, it is associated with the dependence contracture, retroperitoneal fibrosis. Even the fibrosis sometimes can extend back into the larynx. That will cause dyspnea. Okay, that will cause dyspnea, and it will cause problems with the voice also. Okay, voice also. Now, after this, okay, Riedl's some more important points which I want you to know. Whenever you try to do the fine needle aspiration cytology, okay, now the thyroid gland is fibrotic. The word they will use is, it's so much fibrotic that it looks like a wood. Okay, it's woody hard. Okay, that much hard, it's woody hard. Okay, so are you able to perform fine needle aspiration cytology? Okay, by taking a needle, are you going to put a hole into the thyroid gland? No, it's not possible because it's such a hard thyroid. So fine needle aspiration cytology cannot be done because there is woody hard. The thyroid gland is woody hard and it mimics a cancer. There is one more thyroid cancer. Okay, see, that cancer is called as anaplastic cancer. Okay, that cancer is called as anaplastic cancer of the thyroid gland. Now in that anaplastic cancer also, the thyroid is like, it's a stony hard, we will say stone hard. So in both the cases, you cannot able to perform the fine needle aspiration cytology. So if you cannot perform the fine needle aspiration cytology, they are more like same, right? So that's why we say it mimics, okay, this Riedl's thyroiditis. Okay, Riedl's thyroiditis, it mimics anaplastic carcinoma of thyroid gland. Okay, so this also always produce hypothyroid. Okay, always produce hypothyroid, and there will be compressive symptoms. What are these compressive symptoms? The thyroid gland will compress the larynx back, so that will cause dyspnea. Okay, and even sometimes the laryngeal nerves, okay, recurrent laryngeal nerve, that might be compressed, that will also cause the same thing. Okay, respiratory problems. Now let's talk about the DeQuervain's. See, this DeQuervain's thyroiditis is the post-viral thyroiditis. That's the important point. Okay, so DeQuervain's thyroiditis is also called as a post-viral thyroiditis or subacute. Okay, subacute thyroiditis, which is viral in origin. Okay, viral in origin. See, it is associated with HLA-B35. Okay, which is not that important, but important is, see, which thyroiditis is seen after the viral infection? DeQuervain's thyroiditis. Important point. See, in DeQuervain's thyroiditis, the important point is usually all the thyroiditis, okay, they predominantly present as hypothyroid. But this DeQuervain's presents mostly as hyperthyroid. See, predominantly hyperthyroid with a pain for long period. Okay, long period. There is pain, and there are features of hyperthyroid. But even they later becomes hypothyroid. So the question will be something like this: which thyroiditis is majorly present as hyperthyroid, or which thyroiditis predominantly presents as hyperthyroid? It is DeQuervain's. Okay, so that's the important point which I want you to know. At the end of the day, even DeQuervain's will also lead to hypothyroidism. And what is the differential diagnosis? See, Graves' disease is the most common cause. Okay, Graves' disease is the most common cause of hyperthyroidism. True. So hyperthyroid features are there. Now this thyroiditis, DeQuervain's thyroiditis, predominantly presents as, again, hyperthyroid. So in DeQuervain's thyroiditis, hyperthyroid. Even in Graves' disease, hyperthyroid. So how to differentiate between these two conditions is by study called as radioactive iodine uptake. In Graves' disease, see, in Graves' disease there is increased radioactive iodine uptake. Why? Because Graves is the stimulates the autoantibodies, stimulatory antibodies, long-acting thyroid stimulating antibodies are stimulating the thyroid gland. So thyroid gland is taking up the iodine. It is producing more and more thyroid hormones. So what happened to the iodine uptake? What happened to the radioactive iodine uptake by the thyroid gland? If you give radioactive iodine, all this radioactive iodine will be taken up by the thyroid gland for the production of T3 and T4. So what happened to RAUI? RAUI is increased. More radioactive iodine will be taken up by the thyroid gland for the production of T3, T4. But in DeQuervain's, there is no production. It's just the inflammation of the thyroid gland, which is leading to spilling of the T3, T4. So in DeQuervain's, the radioactive iodine uptake is not increased. Okay, not increased. Okay, so these are some important points which I want you to know regarding the thyroiditis. Okay, anyway, you will study the thyroiditis in detail in the pathology. So I want you to know these things at least. Okay, so with this we are done with the important differences between the T3 and T4. hyperthyroidism as well as the hypothyroidism, and also we have seen some important points regarding thyroiditis. Hope the video is helpful. See you in the next video. Thank you.